Hello. Okay. Today we are going to talk about interceptive orthodontics. So, what are the learning outcomes for this lecture? Now, at the end of this lecture, the student should be able to define what is interceptive orthodontics, describe the different procedures undertaken as part of interceptive orthodontics, should be able to define what is serial extraction and outline the advantages and disadvantages of serial extractions, and also explain the role of muscle exercise as an interceptive procedure. Okay, a word about prevention versus interceptive. Okay, prevention means it's to stop the malocclusion from happening in the first instance, and it means that it's predicted or expected that a malocclusion will develop in the future, and the steps taken to prevent this happening. Interceptive orthodontics, on the other hand, is the uh, procedures to modify or lessen the negative effects of a malocclusion where the malocclusion has already begun to happen. Okay, now there are various definitions for interceptive orthodontics. Okay, this one by De Linden, he defines it as the guidance of the development of the dentition through minimal intervention with the aim of preventing, reducing, or correcting existing or potential abnormal tooth positions or malocclusions. Now, Chung and Kerr defines it as any treatment which eliminates or reduces the severity of a developing malocclusion in order to eliminate or simplify the need for future treatment. In other words, by doing interceptive treatment, your future corrective therapy is much simpler, or there might be no need for any corrective therapy. Okay, Profit says that interceptive treatment can be very helpful in reducing the severity of the problems, but rarely is it so successful that later stages of treatment are unnecessary. What he says is that means even with interception, you may still need to do corrective orthodontics at a later stage. So it doesn't completely eliminate the need for later intervention. Okay, what are the advantages of early treatment? Now, the advantages are: one is the psychosocial benefit to the patients. Okay, as we know, like for example, patients with severe overjets, they tend to be teased and bullied, and this can affect the patient psychologically. So by having early treatment done, um, this may put an end to the bullying and teasing, which has a psychological benefit for the patient. Okay, and also studies have shown that procline teeth are prone to trauma, and by early intervention, there is a possibility of reducing the chances of trauma to the teeth and also to the soft tissues from occlusal discrepancies. And also at a younger age, the craniofacial tissues are more modifiable and more amenable to treatment. And also for functional interferences are better corrected at an early age. Okay, so early treatment is not without its disadvantages. One is early treatment is done at a time at the age of the patient when cooperation is not very forthcoming. Okay, there's poor cooperation because these are young patients, and sometimes interceptive treatment involves extraction of teeth, and it is difficult to decide which teeth to extract and when, because it is very difficult to predict what will happen in the future. And also, Wick and Cohen has shown that soft tissues matures late, meaning, in other words, the soft tissues that you see in a child of, say, 9-10 years old is not going to remain the same at a much later age. Okay, and arch development, Little has said that arch development gained in during interceptive treatment is usually lost in the permanent dentition. Okay, now to be able to understand, to be able to undertake interceptive orthodontic treatment, one should understand normal skeletal and dental development. And once you understand what is normal skeletal and dental development, you'll be able to recognize any developing anomalies, and also we will be able to predict what possible future complications may arise. Okay, so to start with, we have to establish what is normal. Okay, now dental norm. Okay, now when we talk about dental norm, what we want is a complete deciduous dentition with mild spacing, okay, which are known as primate spaces. Okay, now these primate spaces are important because uh, the size of the permanent dentition, the permanent teeth, is much larger than the deciduous teeth which it replaces. Now, if the deciduous teeth are not spaced and they are in close contact, that means there will not be enough space in the arch to accommodate the much bigger permanent teeth. Okay, and the incisor relationship should be a edge-to-edge relationship. There should be no cross bites either anterior or posterior, and the molars, the primary deciduous molars, should be in a flush terminal relationship or a mesial step relationship. Now, what? Okay. Now, if you look at your ears, upper and lower ears, they can either be straight like this, which is known as a straight or flush terminal plane, or the lower molars are slightly forward, which creates a mesial step, or the lower molars are placed further posterior to the upper molars, in which it creates a distal step. Now, the most desirable arrangement is the mesial step arrangement, or if a flush terminal relationship. The distal step relationship is a favorable uh, uh, not a favorable arrangement. Okay, skeletal norm. In skeletal norm, we want a class 1 relationship, ideally a straight facial profile, and we want balanced jaw relationships in all three planes of space, that is vertical, transverse, and AP. A functional norm, we want a normal swallowing habit. Nasal breathing is preferred over mouth breathing, and there should be no presence of no digit sucking habit. Okay, now there is a lot of overlap between prevention and interception, and it is very difficult to define separate purely prevention and purely interceptive procedure. Okay, and very few procedures are purely preventive. Okay, let's look at the etiological factors of malocclusion. Okay, you have skeletal factors, you have soft tissue factors, and you have local or dentoalveolar factors. Now, what is the scope for interceptive treatment? Okay, if you look at skeletal and soft tissue factors, these are under tight genetic control, and there's less scope for intervention in modifying skeletal and soft tissue factors. Now, local factors are more amenable to interception as they can be modified. Okay, now what is the best time for interceptive treatment? The best time for interceptive treatment is during the mixed dentition stage, where the dentition is transiting from the deciduous to the permanent dentition. Now, what are the possible problems that may arise? Okay, you can broadly divide them into three large groups. One is involving local factors, one is involving soft tissue or habits, and one is involving skeletal factors. Okay, so under local factors, we can have eruption anomalies, ectopic eruptions, space problems, occlusal anomalies. Under soft tissue and habits, you have digit sucking, tongue thrusting habit, and mouth breathing habit. Now, skeletal discrepancies can occur in all the three planes, transverse, vertical, and AP, and there can be a combination of the three planes as well. And you can get facial asymmetry, and you also get cleft lip and palate. Now, let's look a bit more detail into these problems. Okay, now let's have a look at eruption anomalies. Quite commonly, we will get delayed or non-shedding of the deciduous teeth. Okay, means the deciduous teeth does not fall off. Okay, and these deciduous teeth are normally shed when the root of the permanent successor is 3/4 complete. Now, what can cause a delay in this process? Now, one of the reason is if your deciduous uh, teeth is ascaris or has become necrotic due to trauma, and this necrotic deciduous root is can be difficult to resolve, and when it's difficult to resolve, the permanent successor tooth which is developing will get displaced, and that ends up in an anterior crossbite. Okay, now the treatment is to extract the retained deciduous teeth so that the permanent teeth can come into a better alignment. Now, other eruption anomalies, okay, involving supernumerary teeth. Okay, supernumerary teeth, as the name suggests, means extra teeth. Okay, these are teeth in addition to the what you normally find in the dentition, and it is more common in the permanent dentition compared to the deciduous dentition. More common in males, more common in the maxilla, and about 80% of them occur in the anterior maxilla. There may be a hereditary element uh, involved in the occurrence of supernumerary teeth. Now, there are two types. One is, of course, the conical supernumerary teeth, and the other is the tuberculate. And usually, the conical supernumeraries will erupt, and very frequently, the tuberculate type remains buried and unerupted. Now, there's another one which is called supplemental or paramolar supernumerary teeth. Now, these are basically supernumerary teeth that resembles, in terms of shape and size, resembles the normal series. It's sometimes difficult to tell which is a supernumerary and which is the normal series. Now, the effect of all supernumerary teeth is they can cause spacing or diastema, and they can cause displacement or rotation of the permanent teeth, and they may also prevent the eruption of permanent teeth. Now, the treatment for supernumerary is usually to extract the supernumerary, but sometimes, occasionally, we can elect to keep the supernumerary teeth and take out the tooth of the normal series if the tooth of the normal series is carious and has poor prognosis. Now, if the decision to extract has been made, then it should be done as soon as possible, as the earlier the extraction is done, there is more chances of spontaneous alignment of the or eruption of the permanent tooth. Okay, this is an example of a mesiodense. It has erupted in the midline, and it has caused the 2-1 to be displaced distally. Now, this has come at the expense of the space for the later developing 2-2, and as you can see here, the 2-2 has been displaced palatally. Okay, now delayed eruption of a permanent incisor. What can cause this? Okay, as we have seen earlier, it can be caused by late shedding of the deciduous incisor, early loss of deciduous teeth resulting in thick fibrous covering. Okay, so it is not only the deciduous teeth shedding late, but even if the deciduous teeth is shed early or lost well before its time, what happens is the tissue overlying the permanent developing teeth becomes thick and fibrous, and this can also delay the eruption of the incisor. Okay, and a presence of supernumerary teeth which is obstructs the eruption of the incisor. Okay, now the treatment is, if the permanent incisor is superficially placed, all we may need to do is to excise the mucosa to create a window for eruption. If it is deeply placed, then we will need to create the space and then expose and bond a gold chain to the tooth for traction. Okay, impacted canines. Okay, now impaction means the tooth is does not erupt into its normal position in the mouth, and it's gets obstructed to and is unable to further erupt. Okay, now the most common teeth involved in impactions are the third molars, and the canines are the next most common impacted teeth. Now, why the canines very frequently get impacted is because developmentally the canine develops close to the nasal floor, and thus it has a long eruption path whereby to reach its final position in the oral cavity. And the canine may also be ectopically positioned, and very frequently impacted canines are associated with microdon or small or missing lateral incisors. Now, there may be a hereditary component as well to the occurrence of impaction, and impaction can be either on the palatal side or on the buccal side, and the majority of them are on the palatal side. It also affects the females more than the males, and normally it is unilateral in occurrence compared to bilateral, and occasionally in 12% of cases it also causes resorption of the root of the lateral incisors. And with the teeth being impacted, the deciduous canines will maybe retain behind their normal shedding time. Okay, now in the mouth, where it is impacted, we find that there is no palpable canine bulge. Okay, or it may be discovered as a radiographic finding. Okay, here we can see this is a OPG view of a patient, and we can see both the 1-3 and 2-3 are impacted, and there's no space for it to erupt into the oral. This is an upper anterior occlusal view, another example of impacted canine, and this probably has got a dilacerated root as well. Okay, as you can see here, we see here a microdon lateral incisor, and the uh, permanent canine is missing. So this is very common, whereby the impacted permanent canines are frequently associated with microdontia or hypodontia, especially involving the lateral incisors. Okay, what is the treatment for the impacted canine? We can extract the C's and, if necessary, B's as well. And if safe space is sufficient for eruption, then we need to maintain the space. And if there is lack of space, then we may have to consider extraction of first permanent premolar to create space for eruption. Okay, and if we are extracting the C, the extraction should be done as early as possible. This is because the impacted canine is more likely to spontaneously erupt if its root development is not complete. Okay, now let's look at anterior diastema. Now, anterior diastema is a space between the upper central incisors. Now, the incidence of anterior diastema varies according to age, and it progressively reduces with age. In 12 to 18-year-olds, the incidence is about 7%. Okay, now if the diastema is less than 2 millimeters wide, it's most likely is physiological, and it may be a reflection of the ugly duckling stage. Okay, now if it is more than 2 millimeters in width, it could be due to a mesiodense or an unerupted odontome, or it could be due to a thick lowly attached labial frenum, or it could be simply be an expression of microdontia and or hypodontia. Okay, now the treatment is to establish the cause of the anterior diastema, and if it is a physiological cause, which is the ugly duckling stage, then we need to advise and reassure the parent and patient that it will most probably close as the canine erupts. Now, the ugly duckling stage is caused by this. If you look at this diagram, the canines are not erupted yet. They are still lying high up in the alveolus, and the crown of the canine is in close relation to the roots of the incisors. Now, this results in the roots of the incisors being brought close together and causes the crowns to move distally, which creates the diastema. Now, when the permanent canines erupt into the oral cavity, the crowns comes into contact with the crowns of the incisors, and this moves the crowns mesially and moves the roots distally, and this will improve the alignment, and the diastema will close. Now, if the diastema is caused by any obstruction or presence of any odontomes and things, then we will need to remove these obstructions. Okay, and after the diastema is closed, we will need to do a frenoplasty in the cases of, especially in the cases of where the cause is a lowly attached frenum. Frenoplasty can be done to reposition the frenum in a more superior position. Okay, let's look at serial extractions. Now, serial extractions are sequential extractions done to relieve crowding, and this was first introduced by Jelgren, and it was later modified by Duell, okay, which is the CD4 technique, okay, and whereby the first the C is extracted at the first stage to allow eruption of the permanent lateral incisors. Subsequently, the first deciduous molars or Ds are extracted to allow eruption of the first permanent molars. And the last stage, the first permanent molars are extracted to allow eruption of the permanent canines. Now, the aim of this serial extraction is to relieve anterior crowding. Now, the indications for undertaking serial extractions are lack of space or reduced arch length as evidenced by crowding, a severe class 1 malocclusion. Now, patient must be in the mixed dentition with a normal overbite. All the teeth should be present and are sound. And developmentally, the first permanent premolar should be way ahead of the permanent canine. Now, what are the disadvantages of serial extraction? Now, the results is unpredictable and it is difficult, as I mentioned, it is difficult to predict future growth. And serial extractions only shift the crowding from the labial segments to the buccal segments. As we align the labial segments, the crowding shifts to the buccal segments. Now, and it also involves at least 3 stages of extraction, and this can be a traumatic experience for the patient. And despite all this, corrective treatment may still be needed later due to deepening of the overbite. Extraction spaces may not close completely. The incisors tend to get inclined lingually, and the canines gets angulated distally, while the second premolars are angulated mesially. Okay, cross bites. Now, the incidence of cross bites is about 7.7%. There are various types of cross bites. They can be either skeletal cross bites, they can be caused by dental, which can be further divided either into generalized or localized, functional cross bites, and there can be a combination of both, all the 3 types. And in terms of location, it can either be an anterior crossbite or it can be a posterior crossbite. And posterior crossbites further can be divided into unilateral and or bilateral crossbites. Anterior crossbites. Okay, if 3 to 4 incisors are involved, this commonly occurs with a skeletal class 3 pattern. And the class 3 can be a true class 3 or can be a pseudo class 3. Now, a pseudo class 3 means the class 3 is due to the forward displacement or deviation of the mandible due to occlusal interferences. Now, if 1 to 2 incisors are involved in the crossbite, is usually commonly due to dental or local factors. Now, what are the factors that can cause these? One is supernumeraries or odontomes may displace the permanent teeth and cause them to come into a crossbite relationship. Trauma to deciduous incisors, retained deciduous incisors, because this will delay or displace the permanent successors. Now, crowding usually affects the tooth lateral incisors because these incisors erupt later than the central incisors, and usually these are affected by the crowding. Now, what is the effect of all this is the space loss due to arch contraction. There can be gingival trauma due to occlusal interferences, and the mandible deviates on closing, and this can lead to temporomandibular joint problems later on. Okay. Now, anterior crossbite. Now, space is available for alignment of the tooth or teeth in crossbite, the simplest way to correct this is to use a tongue blade. Okay, usually effective. It involves only one or two teeth, but the success depends on patient compliance. Okay, and it has to be used at least minimum 5 minutes per hour. And because of this, the success rate is usually not very good. One could also use a lower bite plane called a Catalan's appliance. Now, this is either acrylic cemented on the lower teeth, meaning fixed, or it may be the bite plane may be incorporated on a removable appliance. The bite plane is usually 45 degrees and it's usually only touches the displaced tooth. It's used for a short period for 7 to 10 days. The other modalities of treatment are to use a removable appliance or fixed appliance. Now, anterior crossbite. This is an example of a removable appliance. This is a cross cantilever spring. This is a single cantilever spring, and this is a double cantilever spring. Okay, we can also use removable appliances carrying screws. Okay, now let's have a look at space management. Now, space management is the use of appliances to maintain space in the dental arch due following early loss of deciduous or permanent teeth, and they assist in the proper eruption of successor or other teeth without any obstruction. You'll need to do a space analysis to determine the amount of space required. Now, we also need to remember that arch length will reduce during transition from primary to permanent dentition. Okay, now the space loss after early loss of a teeth occurs mainly within 6 months of the loss of the teeth. Now this means that if we should fit a space maintainer as soon as possible to minimize the loss in space. Okay, now how does this space loss occurs? It can occur by either mesial or distal tipping of the adjacent tooth, and in the case of upper molars there's mesial rotation as well. Now, if there is a delayed eruption of the permanent teeth, we may be able to extract the deciduous teeth to quicken the eruption of the permanent teeth. Now, if there is a congenitally missing permanent teeth, for example a lateral incisor, then a decision has to be made whether to close or maintain the space. Okay. What happens if space is not maintained? If space is not maintained, then there will be drifting and tilting of the adjacent teeth, and this will result in a loss of arch length, and also there will maybe shift of center lines, especially if the loss is not balanced. And there will be, once there's loss of arch length, permanent teeth tend to be crowded and may even get impacted, and all this will mean that one would need to do comprehensive treatment and for with probably extraction of teeth. Okay, two effects of loss of permanent teeth is mesial drifting and also the shift of the midline. Okay, now usually mesial drifting is more prominent as we go towards the molars, the back of the mouth, and posteriorly, and the midline shift is more prominent as we move towards anterior part of the mouth. So the greatest midline shift will take place if there is loss in the C's. Now, if the first or second deciduous molars are lost early, the first permanent molars drifts mesially, resulting in the reduction of arch length. Now, this space that is lost can be regained by moving the first permanent molars distally, and preferably this should be done before the eruption of the second permanent molars. Now, space regaining can be done using a Gerber space regainer. Now, this appliance has got a band cemented on a molar tooth, and it's got a loop fashioned that goes to the adjacent teeth on the uh, space area adjacent to the space, and it is got a coil, a closed coil which can be, sorry, a open coil which can be compressed to activate the appliance, and this will drive the canine distally. We can also use a jack screw on a removable appliance, or you can use a cantilever spring carried on a upper removable appliance. Now, habits can be due to digit sucking or use of pacifiers. Now, it's common habit for young children, and it may be normal up to the age of 3 years. Now, the effect of digit sucking habit on the dentition will depend on the frequency of the habit, the intensity, meaning the force exerted by the digit, the duration of each episode, and the method, whether a thumb is used or finger is used, or whether it's a pacifier. Okay. Now, the effects of digit sucking are on the occlusion is it creates a open bite. The open bite is because of the presence of the digit between the upper and lower dentition, preventing the coming into contact of the upper and lower dentition. Okay, it can cause proclination of the upper incisors, again due to the force of the digit on the upper incisors, and similarly it can cause retroclination of the lower incisor, and it can also cause a posterior crossbite. Now, the adverse effects remain minimal if the habit is stopped before 6 years of age. Okay, this is an example of an open bite due to digit sucking. As you can see, the shape conforms to the presence of a digit. Okay, now why digit sucking causes posterior cross bites? Now, this space which is here, which is normally occupied by the tongue, is occupied by the digit, and the tongue occupies a lower position during digit sucking. And during digit sucking, the buccinator muscle, the perioral musculature, exerts pressure on the dentition. Now, the pressure on the lower dentition is resisted by the lower presence of the tongue. But unfortunately, in the upper arch, the pressure on the upper dentition is not resisted by the tongue because it has been depressed into a lower position by the digit, and this creates a posterior crossbite. Now, the malocclusion, any developing malocclusion will self-correct if the habit is stopped before 6 years of age. Now, parents' involvement, they should encourage the child to stop the habit by using a reward system. Okay, praise the child for any improvement in stopping the habit, parents should avoid nagging the patient, and they can use habit reversal therapy. Now, it's the importance is the concept of therapy is to use reminder therapy. Okay, this is to remind the child not to suck their digit, as sometimes frequently these habits are done subconsciously. Now you can use a finger bandage, a finger pain, boxing gloves, or even a thermoplastic finger post. Okay, or you could use a habit breaker appliance, which also functions as a reminder appliance. But for it, any of these appliance therapy to succeed, most importantly, the patient must want to stop the habit. Okay, it should be pain free and there should be occlusal interferences. Okay, so these are the various methods. Okay, this is a loop carried on a removable appliance, or as you can see here, on a fixed appliance. And this is a bluegrass appliance, examples of bluegrass appliance, which can also be utilized to stop the digit sucking habit. So tongue thrust. So this is when the tongue makes contact with the anterior teeth during swallowing, and it can cause an open bite malocclusion and anterior proclination of the incisors. Now, habit breakers can help with the correct swallowing technique. Now, mouth breathing is usually caused by some form of obstruction along the upper respiratory passage. This can be nasal polyps, it can be a deviated nasal septum, and it can, even after the cause is removed, the habit can still persist, and a vestibular screen can be fitted as a habit breaker. Now, muscle exercises. Some children present with mild protrusion and spaced after incisors in the mixed dentition stage, early mixed dentition stage. Now, and usually the lips are frequently hypotonic and flaccid. Now, Rogers proposed various perioral muscle exercises to increase the tonicity of the muscles. And these muscles may aid in the self-correction of mild cases, and they also prevent the development of abnormal lip and tongue habits that worsen malocclusion. To be effective, it has to be done at least 30 minutes per day for 4 to 5 months. Skeletal discrepancy. Skeletal discrepancy are caused, there is a debate whether they are under tight genetic control or are they caused later modified by the environment. The final jaw size and shape is believed to be under tight genetic control, and this gives rise to the question whether growth can be modified. Okay, now functional appliances, again the effectiveness is questionable, but it reduces the chances of injury to procline incisors. So whether or not we actually get skeletal correction, it does have some benefits. Okay, and it utilizes the pubertal growth spurt, and but this herein also lies a problem in that growth spurt timing is very difficult to predict. There's various ways have been devised, for example, wrist radiographs, height measurements, and looking at the ossification of the cervical vertebrae. But these techniques are not perfect, and the success of functional appliance also depends on a high level of patient compliance. Okay, now this compliance sometimes is not forthcoming because functional appliances tend to be bulky in construction, and the patient has to be highly motivated to produce a high level of compliance. Okay, in class 2 relationship where excessive maxillary growth, prognatic maxilla, we can use a face bow with headgear to restrain the excessive maxillary growth. Now, in a class 2 where the mandibular growth is deficient, we can use myofunctional appliances, okay, such as twin blocks, Frankel 2, bionator. Now, in a class 3 skeletal relationship where the maxillary growth is deficient, we can use a reverse face mask therapy or a Frankel 3. Now, usually this therapy has to be taken at an early age, as because as maxillary growth is complete much earlier compared to mandibular growth. Now, in class 3s where there is excessive mandibular growth, one could use a chin cup with headgear to attempt restraint of mandibular. Cleft lip and palate. Cleft lip and palate, uh, the dental alveolus develops from the branchial arch, and they usually develop in three parts: the right, left, and the premaxilla. And sometimes, due to various reasons, these parts which are developed separately may not fuse as they normally should, leaving a cleft. In this case, this is a unilateral cleft, okay, and there's deficient of bone, and there's no continuity of the alveolus, okay, and this results in a arch collapse, and also there is lack of bone for the eruption of the canine on the permanent canine on the cleft side. Okay, now here is a photo of a bilateral cleft lip and palate. This is an extreme case where complete collapse of the arch has taken place. Okay, and also because of the deficient bone around the cleft side, there is lack of alar support for the nose, resulting in a distortion of the nose. Now, cleft to restore the continuity of the alveolus, a procedure known as alveolar bone grafting is done. Now, this will restore the arch integrity in terms of size and shape, and it provides a bony bed for the eruption of the permanent canine. Okay, the timing of this is critical. Ideally, it should be undertaken when the canine root is about 2 complete. Now, these are some of the procedures that can be done as an interceptive measure, and the role of the examiner or the operator, especially a non-specialist, non-specialist, is they should recognize this developing or established malocclusions early and refer to a specialist unit for early treatment. Whatever is done is should not we should avoid making the malocclusion worse due to neglect, which means no treatment is given at the appropriate time, or inappropriate treatment is given on, or an appropriate treatment is withheld. Okay, now operators, non-specialist operators can manage simple cases, and usually simple cases involves movement of only one or two teeth, but it's very important to do a proper case selection. Now these are the references for this lecture, and thank you.